Okay, so brief introduction. My name is Nate Stuckey. I am the clinical pharmacist, and I work here at Fort Wayne Med Ed, and I work up in the Family Medicine Center. So historically, my training has been with old people and chronic disease. So full disclosure, women's health and perinatal things is outside of my wheelhouse, but I figured I'd give you some useful tools and useful tricks that I actually do when the residents come in and ask me tons of questions, or my family members ask me questions, or my wife, who's a social worker, asks me questions, the people she works with ask me questions. So today, we're really going to define what those pregnancy risk categories are, because there's a lot of debate of what those categories actually are. In the last 3 years, they've kind of changed how they're kind of stratifying those risk categories. We're going to discuss common psychotropic medications and how they're used during pregnancy. This is going to be very, very general, very brief, because I really want to talk about this last one. Identify resources for both patients and for you guys. You guys are all on the front lines, and it's very, very difficult when you're sitting there with a client, when you're seeing patients in the hospital, and it's like, they say, I've got this going on, this going on, this going on. I Google search this drug, and what's it going to do? Is my baby going to have 3 heads, or am I going to commit suicide in 2 months if I start taking this? So I really want to talk most and spend most of my time on that section. So first off, it's a question. This is an all skate. I like to ask people questions when I do my lectures. What's more important, fetal health and outcomes, or maternal health and quality of life?
That's tricky.
Yeah, that's a catch-22 question. It's a lose-lose answer. So the thing is, we all care about both. And when we talk to our psychiatrists and those in the mental health field, they're very, very, very focused on the maternal health and the quality of life. But then when you talk to our GYN and our pediatricians, it's all about the fetal outcomes. So a lot of times there's conflict, and we don't know how to resolve that conflict. And unfortunately, I'm usually a huge data guy. I like numbers. I like to be able to dissect and figure out and give you guys exact, clear answers. There are no exact answers. So when we think about these things, we have to have lots of considerations. When we think about medication considerations, what is the risk of an abnormality happening with this medication against the general public? So when we think about people who are just walking around, who aren't being exposed to these drugs, what's their risk of developing these fetal complications or these abnormalities? Sometimes when we hear things on 2020 on the news, we hear this, oh, it has this 30% increase or all these bad episodes. But when we compare it to what's going on in the background, that risk isn't that high. What is the gestational age? So it also depends. When we expose newborns and fetuses at different stages of development, that has complications. Some things are growing and developing at different trimesters versus other trimesters. So drug exposure during that time matters. And then dosage-related risks. So every once in a while, people will say, is it okay if I take some headache medicine? Take a Tylenol once during pregnancy because I have this unbelievable, ridiculous headache. That one tablet of Tylenol in the course of that 40 weeks, very, 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 very low dosage. So the risks are going to be very, very, very low. But if they were taking some of our psychotropic medications that we'll talk about later on for the entire 40 weeks, they're exposed to that all the time. So that exposure risk is significantly different. Finally, what are some complications of that untreated disease? So when we think about mental health, when we think about psychosocial disorders, when we talk about depression, if we forego treatment for the mother, what poor choices are they going to do? What destructive patterns are they going to do? What lack of self-care are they going to do? That's actually going to affect the fetal outcomes. And then finally, after you kind of weigh all those decisions and look at the not great information that we've got and have good conversations with your clients and your patients, you finally have to make that decision. And unfortunately, it's a hard decision to make. So factors that influence tetragenicity. So those are abnormal growth and malformations that occur during pregnancy. So like I talked about, stage of pregnancy, a lot of drugs, if we expose them during the first trimester of pregnancy, that's when a lot of the major development and brain development occurs. So exposure during that time could have ramifications down the road. Maternal and fetal genotypes. So this is a new cutting edge type of medicine. We're starting to do, have you heard of personalized medicine? Have Have you heard about people doing 23andMe and looking at their genotypes? Some people respond really well to our medications that we use for mental health disorders based on their genetic profile. And that profile could also be passed on to the fetus as well, so they're going to have implications and side effects and ADRs. Sorry, I talk really fast, and sometimes I forget and I use jargon. ADR is adverse drug reaction. Dosage and duration of exposure, we've already talked about that. And then there's specific agents. There are definitely agents out there that we know are that big category X, and we do not use them in pregnancy because of the risks that are very, very, very well documented all over the place. Things that when we talk about the complications of medication exposure, it could be no effect. Nothing happens. Very, very simple. Other things that could happen are either premature or delayed labor. We could have spontaneous abortion. That tends to occur in the first and second trimester. We've got malformations. A lot of the times what we're really concerned about is malformations and altered fetal growth. Then functional deficits. So as the fetus's brain is developing, as we expose them to this exogenous chemical, this outside chemical, right at birth, we don't know what that functional deficit's going to be. It's us tracking those patients for a long period of time. What's going to happen? Do they have diminished IQ? Do they have higher risks for things like other mental health disorders? And we don't know that because our data is very, very small. Maybe I'll skip the last thing. This chart looks really, really horrible. But what happened in 2015 is historically the FDA had these nice, simple categories of how we define the risk for the drugs that we gave to people. And they were A, B, C, D, and then X. It was very, very simple. A was okay, X was bad. Then we got into B, C, and D. D we knew pretty much was probably not a good idea, but then B and C, we don't really know. It's very, very gray. The water's very murky. And unfortunately, when we kind of survey all the medications that are out there on the market, not just medications for mental health, but all medications out there, most of them land in that BC range. So that's when you have to sift through information, whether it's good information that we have in some of the resources I'm going to give you guys today, or bad information that we find on Google that kind of sways people and gives them bad and corrupt information. But sometimes it's stuff like, for instance, category C says animal equals, they have animal studies, so they've done it in rabbits and dogs and cats and mice, and they have no developed risk. But we still have no human information. So it's never actually been tried in people. So is that the same? Is that apples to oranges? Or is that apples to pineapples that we're doing that comparison to? Or we have some studies that say animals maybe, but we have nothing going on in people. Or we've got no information at all. So as a result, this category seemed on the surface very, very clear cut, but there was lots of vague grayness in that BC range, which is why the FDA said we need to change this. So starting in the summer of 2015, so a year and a half ago-ish, almost 2 years ago, they actually cited that every time a drug comes to market and things that are already on the market, they have a grace period to start putting these in here. In the accompanied prescribing information, they actually have to have sections that talk about what we do with pregnancy, what we do with lactation, and what we do with male and female reproductive health. I'm not going to go over all those things, but that's the new kind of category. So that's why some of the old stuff you see the A, B, C, D, X, and others will just have a very narrative description. I didn't know there was going to be this many people here, but I did make copies of this chart because I know it was very, very hard to read. So this is I did not create this myself, so I will not take credit for it. On one of my resources, this is my quick and dirty list. It's the most common psychotropic medications that we have on the market, and it's got their general categories associated with them. So this includes the antipsychotics that we tend to use for schizophrenia, schizoaffective disorder. Sometimes we use them as adjunct for mood stabilization. Sometimes we use them as adjunct on top of traditional depression medications. It's got our typical depression medications, and it's also got our mood stabilizers and anticonvulsants. So as you guys see on your sheet, it's got the brand name, which is the common name that most people are very familiar with. it's got what the generic name is, and then it's definitely got the categories here. And as you can see, as you kind of survey these categories, what's the most common category you see there? C. So that either means that we have no information, or we have some very vague information that says it's okay in animals, but it may not be okay in humans. So it's it's hard to make good, concrete decisions. And then this other category, for all of the lactation consultants in here, it's got the breastfeeding category. How much of it gets excreted in the breast milk, what they have to do, what implications are involved with that. So finally, I'm just going to go through some of the most common ones, and this is very, very general. This is not all inclusive, but for our antidepressants, the most common ones that we tend to see are Celexa or citalopram, sertraline or Zoloft, and fluoxetine. I mentioned Zoloft and fluoxetine because they're the ones that tend to be considered okay. And if we look on that sheet, if you look for fluoxetine and sertraline, where are they? They're still both category C. But because we've got a lot of experience with them, we tend to think that those are considered the safest. The big caveat is they all have a big black box warning. Has anyone heard that term, black box warning? So what the FDA mandates is there's a big box warning in all the package information and all the product information that says, warning, before you prescribe this, you need to know this important information. And what that black box warning essentially says is, we don't really know what's going to happen. Weigh the risks and benefits before you continue to prescribe this medication. So they all carry this risk of caution in pregnancy. The one that I always tell people, and that's a category D, is paroxetine, because it's been linked to some cardiovascular abnormalities associated with the fetus. Other things that can possibly occur, some possibly pulmonary hypertension in the fetus, and serotonin withdrawal syndrome. So after the babies are delivered. But when you talk to our mental health professionals, is that next slide? Nope. Generally, the rule of thumb is we generally, if they already have depression, if they're already stabilized on an antidepressant, we generally recommend continuing these. Unless it's paroxetine, then we consider that switch. But ultimately, it's a conversation between everybody who's involved in that patient's care. The patient, the mental health person, as well as the GYN, to make sure they all come to a shared decision and kind of weigh through the risks and benefits of that decision. Mood stabilizers. I just went through the two top most common mood stabilizers, valproic acid or Depakote, and lithium. Depakote is not recommended. Generally, when anybody who is being treated with anticonvulsants or these types of mood stabilizers, they're supposed to have that conversation with their neurologist and their mental health professional about what kind of means are you practicing to prevent pregnancy. Because we know there are bad complications. Category, let's look at my cheat sheet. Depakote is category D or category X. So it's definitely linked to congenital malformations when exposed. So that's why those conversations are had before we initiate these things. And then we come to our antipsychotics. Antipsychotics, like I said before, aren't just used for schizophrenia anymore. They're used as adjuncts for many things. Upstairs in the clinic, we'll use them as adjunct for depression. We know they also have anxiolytic properties, which means that it helps with anxiety. So we'll add on these agents on top of their depression medication to help calm people down, help them sleep better at small doses to kind of as a bundled package. All of them are category C with the exception of two, clozapine and Latuda. I'm not even going to try to say the generic name. Clozapine has its own host of issues. It causes a lot of blood count problems, so they have to be enrolled in a special program where their blood counts are measured every 2 weeks. And if we go back to that last slide, if somebody is on valproic acid or Depakote or lithium for mood stabilization, a lot of times our psychiatrists will consider switching people over to an antipsychotic to help with that mood stabilization because they are all category C with the exception of those two. So finally, this is the resources. So who's got a smartphone? Does everyone have smartphones now? How many of your clients have smartphones or internet access? Would you say most of them do? So let's see if my mouse works. Maybe. Okay. So this is when I used to lecture at Manchester, this is a website I refer all the students to. So the students who are working at CVS, Walgreens, Rite Aid, the pharmacists who will eventually be in the hospitals. It's mother to baby. The reason why I like it is under fact sheet, it's got fact sheets about many medications that we have information on. So it's not just mental health medications, it's medications. So think about the women who you talk to and who you take care of who have rheumatoid arthritis, who have some kind of autoimmune disorder, who have other heart conditions. We want to know, are these medications okay? Or as you, specifically Healthier Moms and Babies and our other organizations who follow our moms after they deliver, or what antibiotics are okay. So it might not be just mental health. It's a good resource to look at these. So let's go to one that I know is there. So as you can see, there is a list of medications here, and they're all in alphabetical order. So we're going to go down to Celexa or citalopram. All you do is click this, and it brings up a fact sheet. Yes, I accept. So on this fact sheet, it actually goes through and walks you through some of those conversation starters and those questions that you would want to have and conversations you want to have with the patient. Talking about what's the chance of some kind of abnormality without being exposed to any of these drugs. Now, what is the chance that this drug is going to cause more abnormalities? And the reason why I like it, it's updated all the time. They update it at least every year based on what new information and data comes out. And it's written for the most part in patient-friendly language. So they can read it themselves. It's a good place and they're very common questions. I am taking citalopram or escitalopram, but I would like to stop taking it before I become pregnant. How long does this medication stay in my body? So that's a common question as people are planning to become pregnant. As we go down to these other ones, should I stop taking this medication when I find out I'm pregnant? What about weaning off the medication before the 3rd trimester? So it has all those things in here, and it tries to put all the good and the bad information in very patient-friendly terms. The other reason why I like it, because most of us don't carry laptops around anymore, they've got an app, and it's free, and all this information, you can go right to it. I've actually got it saved on mine, and it has all the same links. So all the different medications that they're on. If the medication isn't on that list, that means we don't have any information, and it's a big void, dark area. But most of the common things that you will see and that patients are on are going to be on here. Questions about this website and this resource? Yeah.
I actually just have a question in general. You had talked a little bit ago about care coordination between the OB doc and the psych and all that other, so that they're aware of what medications they're on.
Right.
That doesn't happen now.
Correct. It doesn't happen.
I think that, especially for the demographic that we serve, I think it's so important that we sit down, at least, with the clients that we serve, and really it should be happening with everybody, that we have like a monthly meeting with the pharmacist, the psych doctor, and the OB provider, and talk about this person's case so that they understand everything that's going on with them, so that they can really outweigh the risk and the benefits and know what's safe, what's not safe. And yes, this mother needs to be on some medication because some of our moms are schizophrenic,
Right.
suicidal, and they need help and they need medicine. And the only way they're going to be productive, good moms is if we can get their mental health under control by the time that baby's born.
Right.
So how do we do that?
I don't know. That's a great question.
I'm really passionate about it, and I especially just seeing what our moms are dealing with during pregnancy, and I feel like we're setting them up for failure in the end, and we need to have better care coordination between everybody.
I agree, especially with the postpartum depression. Because if they're already depressed and they're already feeling some type of way, it kind of adds to the frustration when the baby gets here. Because a lot of people really doesn't understand how difficult and how stressful and how dangerous postpartum depression can get. So I think medication really, it can kind of help out in lots of areas.
Just looking at the moms, I just pulled some data, and about 37% of the moms that we served last year had history or current anxiety, depression, bipolar, or schizophrenia. And I don't want to overstep my bounds by trying to call the doctor and seeing how we can better coordinate care, but I almost kind of feel like we need to get to that point of doing that.
So welcome to my nightmare, as Dr. Dawson would tell you. Since I work upstairs in the Family Medicine Center, so we're doing primary care. A lot of our patients are referred off to cardiology. A lot of our patients are referred off to either Bowen or Park Center or one of the other psychologists, psychiatrists in town. Some of our patients are off at pain management. As we were going through and doing med reconciliation, so that means we're sitting down, doing a complete medication history and seeing what they've been on. So there's lots of gaps, and even the patients, they say, I don't know what I'm on. I'm on something for my mood, or I'm on something for my heart. So as myself and my students kind of coordinate and do that, we spend, I would say, way too much time on the phone trying to coordinate, find those last notes, trying to find that information, so that way we can provide it to Dr. Dawson and provide it to the residents so they can make good informed decisions about what we're doing as far as tweaking care and tweaking those adjustments and treatment plan. The next two resources, so ultimately if we decide that a psychotropic medication is appropriate for this person, we've kind of weighed the risks and benefits, we've come to a shared decision. Because there's so little data out there, we've got two other resources. So the new recommendation is, if the decision is made to continue on a psychotropic medication, get these women enrolled in a registry. The registry is free. It's a couple survey questions, and the surveyors actually will call them periodically through their pregnancy, and then we'll continually follow them longitudinally and ask them questions and do very survey type information about what outcomes they have experienced with their pregnancy and their newborn. So the two things I'll show you is, the first one is on the FDA's website. And again, if I dropped my email when I signed in, if you guys need these links, I can send these out to you guys. The first one is the FDA registry. There are 103 different registries out there. They cover everything from immune modulators that we use for things like rheumatoid arthritis and other autoimmune disorders, to many of them are around the psychotropic medications, specifically the antipsychotics and the antidepressants. So this resource has got all those on there, and they've got the links to the actual registry to sign those patients up. And then the big one is out of Massachusetts General. So most of those, I would say 2/3 of that registry links to this website to actually enroll people into the antipsychotic and the antidepressant registry. It's free, it's no cost, and there's no complications associated with it. All it is them asking questions and us getting data so we can make better decisions in the future. Questions about the registries? maybe. There we go. So ultimately, I don't have any good answers for you guys. I wish I did, but there aren't any good, clear answers. It's a really difficult decision, and that's why the team approach is needed. That's why there's this, we got to stop operating in our silos that we operate in and actually come together around that patient to actually deliver that good care and actually improve the outcomes for both the maternal side as well as the fetal side and the baby side. And enroll patients in those registries, because the more good data we have, the better decisions we can make. Maybe some of those can go from category C to category B, or actually have good, clear cut what kind of dosing we can do so we can actually deliver better care. What questions do you guys have for me? Thank you.
Thank you.